Welcome back. This is I believe, episode 9. We took a short hiatus between
Just a
episode 8
small
and
one,
9. Yeah.
just a real quick one. It's been a long hiatus, I think is probably the most appropriate
That's a
summary,
good way to
but
put it.
yeah.
We were talking about OBS, and
Mhm.
office-based surgery is something where, this is the bread and butter for us at the practice. So I know that is for you too.
Just for anyone listening who's like you said, residents or maybe even medical students, but like, I guess if you had to summarize OBS, like what is OBS? What does it stand for? And like, what is its purpose, I guess?
Yeah, yeah. So OBS is office-based surgery. And when you say, I don't like that acronym very much. I don't know about you, but like it makes it sound like you're just pulling up an exam chair and doing like laying somebody back and doing surgery. But it's not like
Sure.
that at all. It is,
Yeah.
and I describe it to other people that have never heard of it in the medical field. I'm like, it's the same regimented way of doing surgery as an ASC. We hold ourselves to those same standards of sterility and
Mhm.
patient care that an ambulatory surgery center does. So it's essentially, in my eyes, I don't know about if this is what you think too, but it's the same as an ASC, but understanding that ophthalmology doesn't need the same instruments and tools as maybe ortho or ENT. And that's what an ASC kind of excels at, is multi-specialty care. Whereas OBS to me exceeds all the expectations that you have for an ASC when it comes to ophthalmology. It really excels in personalized care, both for the patient and the surgeon. I mean, that's like your OR. Generally, OBSs are like one surgeon, two surgeons, right? It's not like 25 different surgeons. So
Yeah.
I think anybody will tell you that consistency is key in whatever you do, and to be able for me to have the same staff and the same people both in clinic and the OR every day and have full control over that is such a benefit to patients and patient care. Essentially, it is surgery in the same sort of facility that you would come to expect for an ambulatory surgery center, but
Mhm.
generally owned by that practice. Is that about what you would say?
Yeah, no, I think you said it perfectly, and something I do often tell patients when they come in to see me, and I tell them about office-based surgery and where we'll be doing their surgery is something that you mentioned. It's the same people you saw here today. You're likely the person that helped kind of work you up and get your vision and your pressure and all of that. That person will likely be in the OR with me, either as a circulator or maybe even a scrub tech. And so that kind of cross training, I think, comes in really nicely for OBS. And then, like you said, you develop that relationship where they might just start kind of guessing what you're thinking and helping you out in the OR a lot better than you might be used to. And part of that is due to what you mentioned before. An ASC has to be kind of cross trained, and they need to kind of anticipate, okay, what does the ENT doc need? What does the ortho doc need? What does this ophthalmologist need? Whereas here it's so specialized and it's so focused, and we're just dealing with ophthalmology. And so you develop those relationships with your team, and that transfers over really nicely between clinic and OR and OR and clinic. And so that helps patient care. And I think patients are also really happy when they come into the surgical suite and they're like, "Oh yeah, I remember that person." And it's a familiarity already, so it's not so scary or alarming when they come in.
Yeah, absolutely. So for patients or people that have never heard of OBS and they're kind of skeptical, what are kind of the things that would, and we were at some point hearing about it for the first time. I remember hearing about it and thinking that name office based sounds like infection risk and sounds like problems. It sounds like you're not as careful as you would be at a different facility. I mean, what would you, say to that, or, what would your answer be to people asking those questions?
Yeah, I mean, the first thing I would say is I understand where you're coming from, right? I think the lay public is always trained to think of hospitals, and they're always trained to think of this like big building with it has one purpose and all of that. And so if you're changing perceptions now and you're going into an outpatient clinic, and then someone tells you, hey, you're gonna also have your surgery here in this outpatient clinic, I think that's a natural first response: is how are things going to go here, and is it held to the same standard? So that's the first thing I would say. I understand your background and your thought process. And then the second thing I would say is, well, let me answer all of those things that you just mentioned. It is very safe, and we're holding it to the same exact high standards. And we're trying to do exactly what you get in an ASC or in a hospital, just hopefully better even, and also in a setting that you're just very familiar with. So it's not as daunting or intimidating when you come in there. So, yeah, I mean, just to kind of say basic things, and it might sound really silly, but yeah, sterile processing is done in in a separate location, and it's like that is the place where we sterilize all the instruments, and it's held to that standard. And then, when you walk into actually the OR suite, you are, getting glove, gown, all of that, just like you are in an ASC or a hospital. So all those things that I think are in your brain when you think of hospital setting or OR when you're watching TV, those things are still happening here in OBS.
Yep, exactly. And I think you hit the nail on the head when you were saying we're trying to do all those same things. We're hitting all those benchmarks, joint commission accreditation, the things that prove that we take those steps to be very careful and very sterile, but also doing it in a very patient centered way, giving them the best possible experience. Because while you definitely, for certain procedures, neurosurgery needs to be in a hospital, you have to have an ICU there, you have to have a ventilator. All those things are
Mhm,
like necessary. Ophthalmology, that's just not the right setting for your standard cataract surgery. It's just misplaced at this point. Maybe in the past that was certainly something you needed, but surgical centers, ambulatory surgical centers have really come about on that and realized that ENT, ophthalmology, certain ones don't need that same level of care. Now they still need the same level of sterility and the same level
mhm,
of precision and care, but we can deliver it in a much better way. When I tell patients they don't have to worry about any needles, any IV poke, anything like that, and they see our office, I think and your office is the same way. When they see the level of care that went into designing it and the level of, sterility of the office and the surgery suite being separate, like you said, sterility, the SP, sterile processing being separate and very, very clean. I haven't had anybody even question it because it's just like a surgery center. I mean, all their
yeah.
fears kind of are gone once they see the actual space. And they're like, okay, this is, if you just close your eyes and open your eyes, you're in a surgery center. That's where you are.
Yeah, it is, and I would say it even in a way welcomes or allows family members or friends to kind of be part of that experience. Like for example, this past Friday, I was doing cataract surgery at our OBS, and it was a 75-year-old mother was a patient, but she brought her two children, adult children, 40-year-old children, and asked like, "Do you mind if they watch? Do you mind if they, And we have these big kind of nice glass windows that patients can have their family kind of view and kind of look through
Hmm.
and see also on the big TV screen, the case. And so I walked out of the OR after the case was done, and I was chatting with the family, and they were just amazed. They were just sitting there like, "Wow, that was so cool. We got to see the cataract. We got to see the cataract get removed. We saw the lens that went into the eye. Like we didn't know it was going to be like that, and it was so fast." I think as a surgeon too, I mean, you and I, we both do this day in and day out, and we do so much. And I still think every single time we do it, we're impressed and we're amazed at what we get to do. But it's just so cool to take it to the next level and hear from someone who is experiencing it for the first time or seeing it for the first time and then like getting that joy out of it. I think that's fantastic.
Yeah. Oh, I completely agree. I was thinking of a few patients, just the same thing, where family members can be there and be supportive, and they're always blown away. Yeah. And the OBS allows you to do that even more so. I mean, in ASC, the efficiency that you need to kind of stick to. Not that an OBS isn't efficient, but when you're the owner, when you're the OBS, director, you can take a little bit of time and spend that time with patients and with family. Whereas in ASC, you might not even have that opportunity, right? You might not even have any chance of doing that. That's a uniquely positive thing about OBS that I've found too. For our staff, for family members that want to accompany people.
Mhm.
Yeah, that's a fantastic point.
Yeah. And even another thing that we've talked about before probably on the podcast is just once again talking about patient care because you're there and it is this area in your clinic in your center, you can easily see clinic patients and also do surgery without it being like this big burden like you're traveling to a different location and then you're running back to clinic or something like that. So I think that really helps patient care too. If something pops up and you're like, hey, I do have to see this patient in between OR cases, that's not like a death sentence anymore where you're like taking an hour out of your day to go somewhere else. This is just like, hey, let me walk down the hall and take a look at this patient.
That's so true. Actually, I have a question for you from a logistical standpoint because we have generally had kind of separate OR days and clinic
Hmm.
days, but we
Hmm.
do have some post ops. We have some kind of quicker evals, some follow ups because we can just pop over, see a clinic patient, scrub back in, do surgery, right? But we're trying
Hmm.
to figure out a way. And I don't know what recommendation you give either to me or just anybody in general about kind of scheduling consultations on surgery days so that like
Mhm.
your that side of the staff, like your counselors can have something to do, like while you're
Mhm.
operating. Because otherwise they have lots to do, but like sometimes if you're going 2 or 3 days to the OR, that's not a lot of time, for them to be seeing patients during your clinic. You know what I mean? So kind of
Yeah.
spreading out your evaluation, your evals, onto more days or spread it out over more time. You guys do that
Yeah.
or no? Is it just kind of mostly separate like OR and clinic days?
Yeah. No, I mean, this is a great point. I would say the answer to your question is for the most part, it has been separate OR and clinic days.
Hmm.
But lately, we have been doing or flirting with this process where, for example, a patient that I've already seen, I've already had a consultation with a patient. They
Hmm.
have been deemed, let's say, a good candidate for EVO ICL.
Hmm.
And what I want to do is actually bring them back for a dilated exam and a repeat of measurements and a cycloplegic refraction. And so I know that second exam will be faster. I've already met them, I've already talked to them the first time and done the bulk of kind of my conversation on risk benefit and everything. All I'm doing at this point is just a quick cycloplegic refraction, DFE, a dilated fundus exam, and then also just looking at the scans again just to make sure that nothing has changed from the original set of scans. So we have started doing some of those type of appointments on my OR day, and so that's worked out really well. Where I can pop out of the OR, and while the next patient's getting ready, I can go do this cycloplegic refraction and a dilated exam and take a look at the scans and say, yeah, I'll go ahead and order your EVO ICL this afternoon. And the counselor can kind of take it from there. But yeah, it kind of solves that function or a purpose of being able to do another exam, the counselors being able to kind of finalize discussions with the patient, and the patient being able to get things done without needing yet another exam on a day where I'm not in the OR.
Gotcha. That's a great way of doing it. Yeah, we've just been starting to kind of dip our toe in the water with doing that. And the way we've kind of started doing it is seeing an eval before any cases start, like 20 minutes before, and
Mhm.
then seeing one at the end of the cases for the morning. Because we have a pretty solid lunch break. We have like
Mhm.
an hour to an hour and a half lunch. We just enjoy lunch, get to hang out.
I love
And then
it.
we have one that's usually potentially like right after lunch before like the creases start
Mhm.
again, and then one or two after the end of the day. So
Mm.
kind of make
Yeah.
so it's not, but I don't know. I'm also flirting with the idea of doing a few scheduled throughout the OR cases, like taking off one or two cases and putting those on. But it's just, how it is, so hard to exactly schedule how long an eval is going to take and where you're going to be at in the surgical day. So it does
Exactly.
somewhat limit efficiency because OR cases can be so structured. I mean, you can have them every so many minutes and be pretty much on that schedule. Whereas
Yeah, I
clinic,
mean,
adding that in definitely throws off that flow.
yeah, I totally agree with that. And the other thing we have started doing too is technically, if you have a partner, you have another doctor in the office that might be doing clinic while you're doing
Yeah.
OR.
Yeah.
We've had that, and then like for example, my partner, he doesn't do Evo ICL.
Mhm.
And so if he has a patient on his consult schedule that would be a great candidate for EVO ICL, he'll talk to them all about it and kind of
Mhm.
explain everything. And then he'll say, hey, Dr. Koshik's going to be available in a few minutes. Like you can pop in. And so I'll try and do that in between OR cases, or I'll come in, I'll chat with the patient, and then I'll go back to the OR after. So it kind of makes use of that time.
That's awesome. Does he want to come work here too and do Evo eval? That sounds fantastic. I love Evo.
Yeah.
It's amazing.
Evo is fantastic. Yeah. I don't know how keen he would be about doing
Probably not. Yeah. Actually, one of our surgery counselors, after seeing enough patients, she was about a -3 or so. She had
mhm,
Evo herself, and now it's so
mhm.
cool to be able to have her talk with patients and be like, "Yeah, I've had Evo," and then I get to knock on the door and be like, "Hey, I've had LASIK. LASIK's still good too. LASIK is fantastic. It's been
No, I
over a
think I
decade
mean
that I've had LASIK, and it's been awesome." So
yeah, no, I think what you said is great. If you're able to have different people in the office have had different procedures, it's just wonderful, right? Like, I mean, I tell patients all the time, my wife had Smile, I have Evo, and then such and such technician had PRK or LASIK, and yeah, it kind of lets patients know that all these procedures are fantastic. It's just what is the right one for you?
it's not one size fits all. It's
It's
just
not.
really not. And if it was, it'd be so much easier. It would be awesome.
It would be a lot
Yeah.
easier.
I tell people that about lens choices all the time. I was like, if there was one perfect IOL for cataract surgery, our life would be so much easier. But it's just about your life experience with your eyes to this point. and how that dictates what you're going to see afterwards and your measurements of your eye. So many factors that go into what's the right lens for you. And it might not be the same lens for, a husband and wife that are sitting in the same, exam lane. So, yeah, always an interesting
Yeah.
discussion. Yeah.
Oh, yeah. The couple discussions are always fantastic.
I love it. Yeah. I love when
Yeah.
people send like one part of the couple first, they're like, oh, my
Yes.
husband's going to go first or my wife. And then we'll see.
Yeah. They
Then
have a
maybe you
guinea
can do
pig,
my
right?
cataract surgery. Yeah.
Yeah, exactly. Well, I mean, what are some other things that I guess you found with doing OBS that either I guess has like helped your flow or helps patient care or helps you just like make it easier for you?
Yeah, man, there are so many things. The first thing that jumped into my mind though is just how relaxed patients are. We just give them oral, either Valium, generally Valium, but if they want MKO, we'll give them that as well.
Yeah.
Both of those are just anxiety reducing anxiolytic medications that we give to patients before lots of procedures. I mean, it could be a minor procedure in a different specialty. It could be cataract surgery for us. It could be LASIK or EVO. But I'm just so blown away by how it makes such a big difference to not have this like tension building up from the moment they arrive. Like sometimes patients get to a hospital and they're just going to be nervous the whole time, no matter what you do. Whereas in the OBS setting, they come in. It's just like when they came in for their evaluation, and
Mhm.
they just hang out in a nice massage chair. It's super relaxing in the pre-post op area. They're hanging out. They take Valium. We have probably 20-25% of people that don't take anything too. So there's a good
Yeah.
number of people that don't take any relaxation medication, which I don't know
Mhm.
about you, but when I had LASIK, I took Valium.
I definitely took my meds before Evo.
Yeah, so I'm always blown away by the people that don't, and they don't even. Sometimes they don't
Yeah.
even tell me until after. They're like, "Yeah, I didn't
Yeah.
take anything. Can you tell?" I'm like, "No, you were so relaxed." So that's
Yes.
the thing that blows me away the most is just that is so patient focused because you don't want. And what I tell people too is, I'm sure you have people that say, "Oh, you have to knock me out for this surgery. I can't remember anything. You got to put me
Mhm.
under."
Mhm.
And I just tell them like that is less safe in multiple ways than just doing it topically and orally. It's just from a standpoint of safety, like accidents can happen when you aren't aware of things that are going on. You can move, you can be snoring and sleeping and jerking, when you can't control what you're doing. And with cataract surgery, that's a big deal. With other surgeries, if you're working on somebody's knee, not a big deal, right? But when you're working on the eye, it's a big deal if you move your head. So I tell them I want you to have a vested interest in doing well too. It means being at least somewhat awake and aware of what's going on. I don't want you nervous. I want you relaxed, but that helps out tremendously. And then number two is just like complications from the sedation itself. I mean, when people say I want to be completely put to sleep. I'm like, if we put in like a breathing tube for you, or if we intubate you, that risk is so much higher than the risk of cataract surgery. We're talking about risk of death. We're not going to kill you with cataract surgery, but that is something where you're kind of risking your life in order to have cataract surgery. So once we kind of talk about setting expectations and knowing that, hey, if we get started, if we're laying you down and you can't get relaxed and comfortable, we can go to a surgery center or a hospital if that's what you want. We've done that 0 times. We've done that never. But offering it to people lets them be relaxed and let them know, okay, they are just trying to do what's going to suit me best for this procedure.
Yeah, I think yeah, that's fantastic. I'm also very amazed every single time. You made a point where it's like maybe 20% of patients will not take anything and they'll just have the procedure. And I would say yes, very similar with us as well. Whether it's like Evo or custom lens replacement or cataract surgery or even LASIK, where they just don't take anything. And I'm impressed
I am
because
too.
I
I am
I
too.
just remember myself and I'm like, yeah, no, give me something. Like I want to feel a little loose and then these patients are just like, I'm fine, this will be a piece of cake, and they just go through it, and when they're done they're like, yeah, that was fine, everything
Yeah.
was great.
I know. I had
So
this idea because we do some with patients that are on board for like recording things. We're
mhm,
starting to do more recording of like audio and video and stuff. But I have this
mhm.
idea of getting this playlist of just what's the first thing somebody says after cataract surgery in the OBS, and it's almost always like, "Oh, that was easy," or like, "Oh,
Yeah,
that wasn't nearly as bad as I expected," or just all these things that it's like, "Oh, it's over like already."
yeah,
It'd
yeah.
be fun to have like a clip of like 20 of those and just like this is our day to day.
That would be actually that's a fantastic idea because I think, you and I probably are similar in the OR where we're, chatting and we're kinda talking, to the patient, kinda that verbal anesthesia that you
Totally.
always
Vocal
hear.
local, verbal anesthesia.
Vocal
Yeah.
yeah, and I so many times I give patients little like checklists if you want to think about it. Like when I'm doing a capsulorhexis, I'm like, okay, we're already like 25% done here, with
Yeah,
the whole entire case. And then, when I'm putting the lens into the eye, I'm like, hey, you're like 90% done. I'm just, getting ready to clean up here. And I love saying that because I feel like most of the time patients are like 90% done. I mean, what do you we just started. I'm like, no,
exactly.
we're done. And so I think your idea is fantastic. We gotta get these sound clips, and I think that would be a great, public service.
Yeah. And I think for other surgeons, now that you're talking about what you do, because I do something very similar, it
Mhm,
could be very helpful because I'm always trying to fine tune even just the words that I say, like how I
mhm,
say them, what specific words. I mean, there's obviously words that we really avoid saying. Like people in my OBS know not to say the word speculum. With the S word
mhm.
just doesn't enter our vocabulary,
Yeah,
You have an eyelid lifter.
yeah,
That's a good term for it. Yeah. Or we're
yeah,
just going to use this, instrument to help you keep your eye open.
yeah.
I
I
think
think
there's all throughout the case. If you heard somebody, like if you're probably unaware of a lot of things you say, but some things you're very, very like sure about when you're going to say it and how you're going to say it. There's probably some best practices out there for us just in terms of what helps patients. And I try to assess that too, like what helps patients understand what's going on and be relaxed and,
mhm.
give them an expectation of what's coming next. So, yeah.
No, I think, that you're exactly right. The words that we use matter a lot, and yeah, I never say speculum, and no one in our OR says speculum. I'm pretty sure most of the time I say eyelid holder, or
Uh-huh.
sometimes I'll say, "This is just a little support for your eyelid. I don't want it to get
Ooh,
tired,
I
and so
like
it's gonna
that.
help you out."
I'll use that for sure.
Eyelid support.
I love that. Yeah.
But yeah. No, I mean, I think that's always, like, a great thing because when we're talking about OBS too, for these patients that aren't even taking anything, they're
Hmm.
just, "Hey, I wanna go in without any meds." Maybe that vocal local or that verbal anesthesia is even more important, just to keep them comfortable because they didn't even take anything.
Yeah. I think there's a real art form to that too. I mean, it comes with confidence and being a good surgeon. Of course, you have to do that like as a baseline. And I think there's probably surgeons that have I know people that have no interest in doing that. They're like, I don't want to talk somebody through this whole thing. And I
Mhm,
understand that. I get that
mhm,
too. They just want to do the case, do their very best.
mhm,
But I think it's a service to the patient to be able to tell them what's going on. And, if we're going to be operating
mhm,
this conscious state that you got to be telling people what to expect, what's coming next, how they're doing. I think that's just a wonderful way of getting them through what can be a very scary process. But in the end, it's not. But they don't know that going in. Every time I tell somebody that, it's like, you're not going to believe this at this point, but afterwards we'll talk and you'll be like, yeah, you were right. It wasn't scary. I was worried, really worried about
yeah.
it.
And one thing I would say, because you made a point there, like maybe some of our colleagues don't want to talk and they don't want to, verbalize this. And another benefit, I guess, I would say to talking is letting your scrub tech know kind of what you're thinking, because you get two birds, one stone, right? You can tell a patient, for example, I'll commonly say when I'm getting ready to put the intracameral antibiotics into the eye, I'll just tell the patient, "Hey, we're almost done. I'm just going to put a little bit of antibiotic in your eye next." And like that's simultaneously for the patient, but also my scrub tech to know, like, "Hey, you can hand that to me. I'm like ready to go, and let's get that going." So, I mean, these are probably things that you and I and the vast majority of surgeons do, but I think it's nice to think about it from a perspective of you're not only helping the patient, you're helping your scrub tech, you're helping the team, the circulating nurse is aware as well. They can start checking more vitals because we're nearing the end of the case, things like that. That's where that efficiency comes in, and everyone's part of the same team.
Yeah, absolutely. We were talking, and this crossed my mind earlier about OBS and sterility and things like that. And I know that you follow this pretty closely too when we talk about infection risk and things that make a difference. You were talking about intracameral antibiotics there. That's like the biggest thing that makes the biggest difference. And that's not even a requirement with cataract surgery. You can do cataract surgery. If you don't put a lens in the eye, somebody's gonna be like, why didn't you put a lens in the eye? If you don't do intracameral moxie or intracameral antibiotic, a lot of people don't do that. But
Yeah.
I don't it's not obviously not a standard of care, right? But it is, if it's my eye, that's what I would want done. So that's what we
Yeah.
do for our patients. And anyway, just talking about OBS and that allows you to have that control. I was thinking
But
also another tangent was our waste. When you think about
mm,
things that make a difference when it comes to sterility and infection, 99% of what we do makes no difference. And it drives
Mhm.
me crazy the waste that we make. And there's a lot of good people in like AAO and Asker's working on that in terms of sustainability and ophthalmology. But I'm sure you have the same thing where you finish an OR day and you have like almost a dumpster full of trash. And you're like,
Yeah.
a lot of this is completely avoidable. I mean, this is reusable stuff that we could, yeah. So that's
Yeah.
a whole different thing. I'm hopeful in our careers that we can make that change. So
Yeah, that's a totally we could have a whole feature-length podcast just on that topic, but, I mean, that's a great point where, I mean, you look at places elsewhere in the world where they are getting the same results as we are, if not better sometimes in terms of safety and effectiveness, but they're not wasting to the same degree that we're wasting,
yeah,
so,
like 100
um
times less. I mean, not even like orders of magnitude less waste. Yeah.
yeah, and so I think that would be amazing definitely in our lifetime to see some big strides forward in the US with how we manage that kind of medical waste because we know safety and everything is not being compromised. Like, you can still have really safe surgery, really wonderful outcomes, and just be saving the environment and then also helping so many more patients because you're able to reuse material.
Yeah. And we're not talking about like, if you hear us talking about that, we're not talking about like reusing needles, right? We're talking
Sure.
about
Yeah.
like reusing, things that it's like sitting on a chair. Like you're not going to throw that chair out, you're just going to clean it and reuse that chair. It's something that maybe has touched somebody, but not in a way that's at all unsterile. Or it's even parts of like the machines, like cassette machines that never touch the patient that you can just, reuse because it has no patient contact, but we throw those out every case. So it's a lot of things that are like that. Yeah.
Yeah. I mean, that's hopefully something that we'll see a change in, and then definitely maybe even physicians in OBS can lead the charge on that. Who
I was
knows?
thinking the exact same thing. And then I was going to ask
Yeah.
your opinion because I thought about that. And then I thought, do you feel like in an OBS setting, you have to be almost even a little bit more protective of doing anything different outside the scope of what other people are doing? Because it's so much easier to criticize
Mhm.
if there's poor outcomes unrelated, or if there's just people that are just going to criticize because you're changing. I mean, that happens with every change in ophthalmology. There was a time when they said IOLs were a ticking time bomb in the eye, and now we do
Mhm.
billions of intraocular lenses. So it's everything that changes, it gets criticized first. But do you feel like in the OBS setting, like for me, I'm keeping track of all of our post-op day one visits and seeing,
Mhm.
did we do anything different by seeing this person on post-op day one? And can we pinpoint the cases that maybe at higher chance of a IOP spike or something that we are seeing that post-op day one for, versus can we just see them at a week and just check their vision, see how they're healing up, and tell them come in if, and I know there are practices doing that, but in the OBS setting it feels a little bit more uh, difficult to make those changes because people are more critical.
Yeah, I mean that's a great point. I think the answer to your question from my perspective is yes. I do think it's a little bit harder for me to say make a change that I think would help everybody, but may not be so widely accepted right now. And I don't want to be in a position where I kind of make it harder for OBS to kind of take foot everywhere. And I don't want people to then point and say, like, well, you see what happened there, you know. So I think that's a really fine line, and I think the best way, maybe at least for me, I can only speak for myself, is I'd probably wait till certain things are adopted more widely in like ASC hospital settings, and then at least I have that to point to say like, hey, you know, they're doing it there, it's well established. Now I'm going to do it here in OBS as well. But who knows? Those things might change, and we might be able to make improvements of our own. But right now, the spotlight's kind of on. I feel like OBS, and it's hard to shake that.
Yeah, I completely agree. Completely agree. I think OBS could be also leading the charge in some ways for those sorts of changes, but you have to do it in a way that it can't be criticized at all. Just saying, okay, these are
Mhm.
going to be our protocols. We're going to get IRB approval. We're going to do all these things that are like, there's lots of oversight and these are good ideas. And maybe
Mhm.
we're more nimble and able to make these changes first before ASCs and hospitals can. I mean, just trying to even use multi-use drops in a hospital. I've in the last year and a half still had like limited success at the hospitals we go to. They'll throw out an entirely full bottle minus one drop that you used for one patient, and
Yeah.
that feels like a hurdle. It's just hard because that's such
Yeah.
an easy, every professional society in ophthalmology has come out and said it's okay. If you're not
Mhm.
touching the patient's eye, if you do, you throw it out, but if you're not touching a patient's eye with the bottle tip.
Yeah. Yeah, and I mean, to the same point and discussion that we're having, I think you and I both have, same mentor during training who really pioneered in us or instilled in us the safety and effectiveness of same-day bilateral surgery, and we see how well that works in Europe, we see how well that works even in the United States in big kind of groups like Kaiser Permanente, has done that, and so here, I'll do same day bilateral in office based surgery and it's fantastic. But even now in 2026, I will have some patients who kind of balk at that and they say like, what are you talking about? You're going to do both my eyes on the same day? Is that safe? Is that something that can be done? And then I have to kind of counsel them through that. But it's so easy for me now to counsel them through that because I can say, look at Europe, look at Kaiser, look at these big places that are doing it and that have paved the way for establishing that as a safe, method of doing surgery. And then they're like, "Okay, I get it," and I feel comfortable. So I guess, yeah, that's kind of a little bit of my point where I'm like, it's nice when a big organization or a big group or other countries are doing it because then you can really use that as the basis for your justification.
Yeah, absolutely. And I think the volume speaks volumes, I mean, the amount of patients. All of us doing OBS working together could also make an impact. And I think that's something where collaboration in that way to get that number, because in
Hmm.
ophthalmology, I mean, the rates of bad things happening are so low that you have to have tens of thousands or hundreds of thousands of points of data in order to
Hmm.
see any statistical significance for a lot of these things.
Yeah, that's
Not
true.
to get too in the weeds again. Sorry. We keep it more broadly appealing. But I know there's some people out there that are listening that are, nodding their heads along. And I was thinking about when you said Kaiser Permanente, we got to get Max Court on the podcast. Dr. Court
Yeah.
practicing now with Kaiser,
Hmm.
in the Denver Boulder area, and he'd be a great person just to chat with and see
Yeah.
what, because neither of us have that model for what we're doing, and
Don't.
his is unique. So
Yeah. No, I mean, that would be fantastic, and just to get that perspective and also to hear from him because I know he's doing great things.
yeah, absolutely, he's curing glaucoma, which is an uphill
Curing it.
battle
And then, of course, we will, link up at, in Austin coming
in
up because 'cause we'll
Austin.
both see each other, and
Yep.
we'll talk all about EVO IC.
I can't wait, man. I can't wait. That's a wrap on our look at office-based surgery. We're passionate about making eye care simpler, safer, and more convenient for all of our patients. If you found this helpful, leave us a review and share this episode with someone you know. Until next time, we're the eye surgeons, Dr. Sam Berry and Dr. Sud Koushik.